So good afternoon and welcome to today's current topics and healthcare session. Many of you have attended Dr. Unwin's wonderful part 1 to this session presented back in August. And today's session is really intended to provide some resources to make the concepts discussed even more practical for working with patients suffering with dementia and their caregivers. So for those of you who were unable to attend the first session, you will still get just as much out of this session. But if you'd like to view that, a link has been provided for you within your calendar invitation that will lead you directly to the OCPD webpage that includes a PowerPoint, video presentation, and some additional resources that were discussed. Within a week or so of today's session, you're also going to find the details from today's session there as well. And as a side note, for optimal viewing experience, please go to the upper right-hand corner of your Zoom screen and select where it says view, select either side-by-side speaker. Right now I have side-by-side speaker selected, and I hope you all are seeing me. I'm seeing somebody else, but I think that's because I'm speaking. Select side-by-side speaker. If you want to see everybody, you can select side-by-side gallery, but side-by-side speaker will give you the presenter and the slides at the same time. So today's presentation is entitled, Let's Not Forget, Building Rapport with Patients and Caregivers Suffering with Dementia, Part 2. Today, Dr. Brian Unwin, Chief of Geriatrics and Palliative Medicine, will lead a panel discussion of subject matter experts from geriatric medicine, home health, occupational therapy, and the Center for Healthy Aging. I'm going to ask that each of them provide a super brief introduction of themselves during the session, so you'll know who you're speaking to and who where the experts are. So I know we've got a lot to get to today, so I'm just going to fade into the background and let this group take it away. Thank you all so much for being here and for the presenters for taking the time to share your expertise.
All right, so I think I'm speaking now and I'm off mute. Those are achievements for me. Thank you for being here today for part 2 of this discussion about how we can help patients and families suffering with dementia. We'll do individual introductions here as we introduce our sections as they're talking today, but we're going to have a brief recap of our first meeting that we had about a month or so ago, and then we're going to dive into the important areas of how we can help patients and how we can help families that are suffering from this terrible condition. Our disclosures are that we are all Carilion Clinic professionals with either the Center for Healthy Aging or the Carilion Home Health Dementia and Cognitive Care Program, which is truly a unique national entity. I don't think anyone else has a home health program like what we do in supporting our patients and families suffering from dementia. Our learning objectives, brief review of the last session, define what's important in caring for patients who have dementia, and then our experts talking about those individual domains briefly, try to field some questions for you, and then to provide you some resources at the end. So briefly, quickly, recap of part 1. I shared with you my mentor's teaching that geriatric medicine is the medical and social care of the older adult. And the social supports and social elements of care are really the most important thing that support patients and families who have dementia. Secondly, I've learned over time, and my personal mantra is that what I can do as a geriatrics doctor is try to promote the best possible safe function in the least restrictive environment for my patients. And for patients who have dementia, trying to promote their best possible safe function, their quality of life is the most important thing we can do. And it's really not a doctor doing that. It is patients and the caregivers and allied health professions that really help people do this. We talked about the spectrum of cognitive impairment. And a walkaway message that I think I have for everyone is that dementia is not normal aging. And dementia is not a problem with memory per se. It is a problem of loss of cognitive function that then impacts a person's ability to live their life fully and normally the way they used to. And memory may be part of that. Memory may be part of that. Dementia comes in a variety of stages, and the hardest stage is the middle stage in many ways, where basically the patient cannot manage on their own safely and fully and independently, and now others are needed to step up to assist that patient. And that is the longest phase of all the dementing illnesses, and it is only in the severe stages of disease when we start preparing for end-of-life care. And it's this working phase of dementia is what we're kind of really focusing on today. Because the treatment of dementia is different than all the other medical conditions that adults face, in that there's no shot, no pill, no surgery, no cure fix for this problem, but there's caring for this problem. And you'll hear about how to care I hope in our presentation today. Because what patients and families need is engagement. And our role as physicians and physical therapists, nurses, is that we need to engage not just with the patient, but the caregiver. And if we can empower that caregiver, and if we can learn about the caregiver to help promote their function, address their health needs, help them with their behaviors and their mood and their depression, we help the patient who is experiencing dementia. So what's important in caring for patients and families with dementia? Engagement. We want to take patients who are struggling with the depression and the anxiety and the pain and the outbursts and the isolation and move them towards a cohesive plan of care that is collaborative and helps them live their lives to the best that they can. And I think a great plan for that care was developed by the American Academy of Neurology, American Academy of Psychiatry, American Medical Association, and others to create what are called the dementia quality measures. And it was a national meeting involving over 40 agencies to define what is important in caring for patients who have dementia. And we're going to talk about those things today. We're going to talk about the dementia diagnosis with Dr. Ian Reynolds, caregiver education and support with Ms. Amy Shorter-Holland and Ms. Jennifer McPherson, social workers at Center for Healthy Aging. Ms. Lisa Eber-Merritt is going to be talking about functional assessment of patients, screening and treatment of the behavioral and psychiatric symptoms by Dr. Bancoli, a geriatric psychiatrist in our section. Additional safety information from Ms. Wendy Steppe from Center for Healthy Aging. Advanced care planning from, again, from our social workers at CHA. Pain assessment, driving screening from Ms. Rhonda Eilenberg and Ms. Eber-Merritt. And last, and in some ways least, we'll talk about the treatment of dementia with medications with Dr. Bancoli and Dr. Reynolds. And Ms. Amy Shorter-Holland and Ms. McPherson are going to be talking about resources to bring to care for the patient. So we'll start off with Dr. Reynolds. And Dr. Reynolds, I have a question for you. Given that the diagnosis of dementia is a life-altering diagnosis for the patient and family members, how do we go about discussing the diagnosis? How do we go about providing that information to patients and families?
Yeah, great question. Thank you, Dr. Unwin. And for those who don't know me, I'm Ian Reynolds. I'm an internal medicine provider and geriatrician. Have a number of roles, but one of which is a provider at the Center for Healthy Aging. And part of what I do is spend time with patients, and often those who are newly diagnosed with dementia. And I was sitting and reflecting on what that means and what that can look like. And it's a hard-hitting diagnosis. It's a neurodegenerative condition that's not going to improve, that we don't have treatments for, but that we can support and manage. So, and you know, we do that every day, day in, day out as providers and as care staff at the Center for Healthy Aging. So I've come away with some pearls especially when discussing the diagnosis. So this is after doing an initial assessment with the patients, with a thorough family interview, with a thorough chart review, with a review of imaging and labs. And we come to consensus that a dementia diagnosis is most likely. The first thing that I find important is not to assume that anybody knows or has been diagnosed or knows of a diagnosis before they come to clinic. Often I see in charts that people have a listed diagnosis of dementia somewhere in their chart, but we as primary care providers often don't do a great job of communicating that diagnosis, and it's actually quite rare that an individual or their family members are aware of the dementia diagnosis, even though it's written all over their chart. So I don't assume that they've been told or that they know about the diagnosis. So start totally fresh. And I've taken some pearls from Vital Talks and different things. That's a program in palliative care about delivering and having difficult conversations and delivering hard news. And one pearl from that is to deliver the diagnosis sort of as a headline, like you'd read in a newspaper, that's short and to the point, and not trying to dance around the issue. So, you know, the testing is consistent and your story is consistent with a dementia diagnosis. What does that mean? And I give time for reflection because for some, it's sort of expected when we come up with that. Families have been living and experiencing this with their loved one for often years, and so they sort of know or expect that, but others don't. And again, it's a hard-hitting diagnosis, so it's delivering that information succinctly and allowing time for reflection, thought, time for questions, time for processing. And that, you know, can be seconds, that can be, and it can feel like forever, but giving that time to sort of process. And I talk equally to the patient and to the family member. Even if the patient may have more advanced stages of a dementia, I find it important to engage them as much in the conversation as the family member, and really try to work to build alliance with both, recognizing, as Dr. Unwin, that being a caregiver with someone who's got a neurocognitive disorder is a big job and a big responsibility, and it's difficult. And so I like to give accolades and recognition to loved ones and caregivers, and something that some of the other colleagues here at the Center for Healthy Aging also do a fantastic job on. And we'll talk more about that later on in the presentation. And I like to give tangible things that we can do, tangible things that we can offer, things that we can do in the home, things that we can offer in terms of potential treatments, things that we can offer in terms of supports, all of which can have really big and positive impacts on both the person and on the family members to sort of ease their burden of care, allow them to be the loved one, allow them to be the family member, and maybe take some of the onus of being the full-time caregiver. But giving tangible things that we can do for them, and allow for space for expectation setting. This is what this can look like, but give some hope. Again, this is a neurodegenerative condition that won't get better, but people can live meaningful lives with dementia, and give some hope that there can be some semblance of normalcy in their lives. And I think even after giving this diagnosis, and we spend a good hour or more in our clinic visits with families and patients who are newly diagnosed, those things start off feeling bleak when you're giving the diagnosis. By the time we've given some tangible examples and some tangible explanations, and we've given some strategies, and we've given some resources, people leave the visit actually feeling much better. Often are leaving with smiles on their faces and feeling like a little glimmer of hope that they have other people who are advocating for them. And so I think by the end of it, people feel that they can leave with some tools to move forward. And then of course we keep relatively close follow-up with these individuals and follow them throughout their course. And I think they feel reassured that they have a caregiver and a group of providers and an interdisciplinary team who's advocating for them, and have us as a resource. So again, a hard diagnosis and impactful, but I think at the end of the day, people generally feel better by the time they leave our clinic and leave the visit.
We'll have some time at the end. We're going to move on to our next item, and that is the functional status assessment with Lisa Eber-Merritt. And Lisa, just a broad question for you. Why are we assessing function, and why is it important to address the functional abilities of the patient with these difficulties?
Thank you, Dr. Unwin. And my name is Lisa Aber-Merritt, and I am the program coordinator for Carillion Home Health's Cognitive Care / Dementia program. And one of the things that we found were gaps in our medical system when it came to dementia care. So we developed an interdisciplinary, all our nursing and therapy staffs coming together, performing different types of functional assessments in the home environment so that we could establish these very personal plan of cares for our clients and our patients that have a dementia diagnosis. And our process actually starts pre-dementia diagnosis. We are doing functional assessments prior to and monitoring, because that progressive loss in the ability to perform basic activities of living or instrumental activities of living is a primary characteristic in the diagnosing of dementia. So not only are we providing cognitive assessments, but we're also providing those functional assessments to assist pre the dementia diagnosis. And then after receiving a dementia diagnosis, our functional assessments include staging, which includes multiple functional assessments so that we can help families see what level that a patient is currently functioning at in multiple areas of their life, and creating plans of care to help improve function. In some stages of dementia, we can absolutely improve their functional status, but also teaching the families how to maximize a patient's independence through the journey of dementia and keep them functioning at different levels and participating, which helps to improve dignity and care. And it truly takes a village. We have multitudes: physical therapy, occupational therapy, speech therapy, nursing, social works, that all have different functional assessments that they perform. And we collaborate together and we work together. Like, it truly takes a village. And a lot of thinking outside the box after these functional assessments are done to maintain that independence and educate those caregivers at the level to keep them functioning through the journey.
Lisa, can you give us, we've got a minute or so here, can you give us kind of a brief story of an example of that?
So if we go into a home and we all do our assessments, they include bathing, dressing, toileting, hygiene, self-feeding, telephone use, meal preparation, cleaning, laundry, finances, medication management, driving, shopping, guns and weapon use, balance, gait, swallow, communication, safety, depression, anxiety, staging, and caregiver burden. We will go into a patient's home pre or post a dementia diagnosis, do all of that assessing, and then set up, get the patient to the maximum level, do education with the family week by week by week. I mean, with our home health program, we're in from 4 to 8 weeks, and we are consistently several times a week in there working with these families to develop a routine and a schedule and get them, again, at their highest functioning, educate the families how to maintain it or work through behaviors of safety or depression or anxiety, because all of those affect functional status too. And then by the time we come out, we typically have a family managing, finding joyful moments, keeping our patients at that high level. And then as the years go by or the months go by, if there's decline, they bring us back in again. We reassess the areas that have declined using functional assessments again, or cognitive assessments, and we modify where they're at. We re-educate the families and continue care. And our hopes are to continue to stay with those clients and provide that care pre and post a dementia diagnosis through the rest of their span on their journey.
And I think one of the things that all of us that engage in this work would say that, the longer that the patient is remaining functional, and as long as the caregiver is remaining functional, that is a patient and a caregiver that is staying out of the hospital.
Yes.
And then what also we hope and will find in our research is that, these are people that are not then going to the emergency department unnecessarily. And these are people that are delaying long-term care if appropriate. And these are people that are transitioning in a more optimal fashion into hospice care. And so that preserving that function is key.
Mm-hmm.
We'll pause there. We're going to shift gears to another topic here, near and dear to Lisa and Rhonda's heart, talking about driving safety screening next. And I'll turn it back over to Rhonda and Lisa.
Hi, good afternoon, everyone. I'm Rhonda Ehlenberg, and I am the nurse coordinator for the Caregivers Home Health Dementia and Cognitive Care Program. So driving is kind of a loaded question. Did you want to pose the questions, Dr. Unwin, or
Yes.
you just take it away?
Take it away.
All right. So one of the first questions that we always address is, why is it important to address driving upon diagnosis and throughout the course of their dementia disease? And as we all know, especially here in our culture, driving represents freedom and independence and control. So giving that up, or possibly having to give that up at some point, is a hard and sometimes emotional issue. It's taken away their independence. So if we begin to talk about that openly at the beginning of their diagnosis and posing this as a potential thing to think about, going ahead and getting alternatives lined up for if and when this day comes, then when the day does come, it comes as less of a shock, I think, to our patients and our families. Being aware, making the patients aware of kind of the warning signs of when they might need to consider driving retirement, noticing how often we see these sort of warning signs, discussing, looking for patterns of, increased dents in the car, or, is mom or grandma having trouble changing lanes when you're driving with them? Those things are the important sort of triggers that it needs to be thought about more on the soon rather than later aspect. Safety is always the number one concern, safety for both our patients and fellow drivers on the road. So looking for those decreased safety awareness, their mental processing delays, their reflexes delays, confusing the gas and the brake. My mother-in-law lives in Michigan, and she is one that went in to have her hair done, came out and drove through the front of the salon. Praise God, no one was injured, but she simply got the brake and the gas mixed up. Memory at risk of getting lost. We hear this story repeatedly in our patient population. One I remember was going to church Sunday morning 2 miles away from her home here in the Botetourt, Roanoke area, and was found in Richmond on I-81. So it happens frequently. Early education and planning, like I already mentioned, we have a possible driving contract that when they're in the home health setting, we discuss with the families and the patients. So then again, it's just a tool to utilize to begin that conversation. And when it takes place, hopefully you have less denial of that. Changes that may take place during the journey of the stages of dementia, which will bring them, less cognition, decreased learning ability, all those things that are needed for driving.
Rhonda, can you tell us a little bit about the screenings that you do briefly?
Yes, we have, certainly screenings can be started by the PCP, even at our, annual wellness visits, therapy outpatient services, and then we can assist that here in home health. Certainly look at medical diagnoses, other things that may affect their driving ability, vision being a big one. We do
especially for our pre-dementia patients, the MOCA and the slums for cognitive assessments. We look at their physical abilities, their balance, their range of motion, their reflexes, their fatigue level. And then any driving behaviors that may have appeared over time, like I just discussed above, the getting lost, the lane changes, driving too fast or too slow. That is also, driving too slow can be as big of a hazard. Scratches in the car, frequent traffic tickets. We had one patient that got 3 tickets in one day. And then we in home health can also offer some off-road driving assessments that will look at, can they identify the traffic signs? Do they have the problem-solving skills to tell us what would you do if you were in an accident? Simulated brake and gas acceleration testing. Those are all done by our OT mainly. We can also recommend driver rehab if we feel that that is an indication. And, as a last resort, we do contact the DMV if necessary and ask for further review be done on certain patients.
Thank you, Rhonda. And when we talk about our experience with the home health program, we're talking about a lot of experience. To date, since Lisa started this program back in 2015 or so, this program has seen over 4,000 patients. And so there's a broad and deep experience for what this team has seen, and the relationships with DMV and other people that the team has established. We're going to move on to safety concerns, and Ms. Wendy Steppe from the Center for Healthy Aging is going to join us and talk about safety concerns. And Wendy, for this, tell us why we should be worried about safety, and tell me when to change slides, and I'll change slides for you.
Okay, all right. Hi, I'm Wendy. I am a registered nurse. I'm working at the Center for Healthy Aging. I've been here 7 years. So discussing safety and the concerns, what are some safety risks and how we screen for them? There's a multitude of risks that are involved. Dementia affects the judgment and decision-making and decreases understanding of limitations. So, we look at the patient, they come in. First of all, what we do is when we are scheduling our patients, we do an intake assessment, and we ask a lot of questions for the family member about what problems they're having, what is their understanding? Are they falling? Are they eating okay? Are they able to manage their medications? But there's just a broad range of things that we need to be concerned about. Do they have guns? We ask that question on our intake assessment. Are they at risk for being taken advantage of, whether that be physical, mental, sexual abuse, neglect, or exploitation? Are they at risk for wandering? And Rhonda and Lisa talked about the driving. So that's another thing we ask when we're doing our intake assessment. When they come into the office, our social workers, they go in and they update that, because a lot could change from the time we do our initial intake assessment to the time that they actually come in. So it's a continual follow-up. Another thing that we need to look at is, are they depressed? Are there suicidal ideations? Homicidal ideations? So we ask those questions as well. We want to know where they are on that level. You can click it to the next one.
Thank you.
Okay, so basically for the assessment and interventions, what I do when I'm looking at that and asking the family or trying to educate the family, I look at it in a way of child-proofing, although these are not children, but it is like a child-proofing when you have a person who doesn't understand their limitations and their decision-making. You got to do it for them. So, you're just going to go around and store hazardous items such as medications, cleaning supplies, make sure they're put up in a safe place. Firearms should be removed from the home or lock them up. You can also apply gun safety locks to those. Very important. And make sure you know where they are, because some people, real veterans, they might have a pistol somewhere that nobody knows about. So you got to do a really good inventory and know that what's there. And the fall precautions, good lighting, remove any loose rugs, extension cords, any unnecessary furniture or clutter, to make them have an area where it's clutter free to walk, so the fall risk is decreased. And then, of course, touching a little bit on the wandering precautions, 24/7 supervision if needed, Project Lifesaver by the local sheriff's office, nanny cams, wander guard technology, and hallucinations. Are they having hallucinations? Are they having command hallucinations where they're hearing somebody tell them, hey, you need to go here, you need to go there? Are they going to walk out of the house? And even if they're not having those, they're kind of they're looking back and they're feeling like, well, this isn't my home anymore, so I need to go find my home. So these are risks that are there. And of course, you have to look at the early, middle to late stages and assess it. But, it is a team effort. It's family members, caregivers, the healthcare providers. We all have to do these assessments on a regular basis. You can get a lot of good information on these tools at alzheimers.org. So you can get a lot of those health home inventory assessments and tools there. I don't know if I have another one after this.
Mm-hmm.
Basically, in conclusion, it's a progressive disease resulting in a continual decline, both cognitively and functionally. The main goal, like you said before, is the least restrictive but safest environment. And we want them to maintain their independence as long as possible. But we also have to be very aware of what's going on at all times. So that's basically what we do. When, on the intake assessment, we get that original information, then our social workers go in and do the further assessment. And we ask that they call us if there's changes, family members, caregivers, call us if there's any changes, so we know what's going on and we can update and we can get them in sooner, and we can give them more resources. But like I said, alzheimers.org is an excellent resource for families and caregivers.
Thank you, Wendy. And I think I have you up next for the next topic, but this safety concern is one of the most anxiety provoking things for the caregiver to experience, because it kind of freezes that caregiver in their life and trying to do the other things that they're doing, and creating a safety net for a patient is really what it's all about. Another thing that it becomes a very stressful experience for the caregiver is my loved one in pain? And Wendy and Rhonda are going to be talking about this topic.
Okay. You want to go first, Rhonda? Okay. Okay, so I'll start, and then Rhonda, you can jump in at any time.
Okay.
So how do we assess for pain when the person is no longer able to tell us that they're in pain? Basically, you're looking for body language. You're looking for the nonverbal signs of pain when they can't tell you any longer, whether that be their body language, guarding, yelling, crying, inconsolability, breathing, facial expressions, increased agitation, anxiety, and being combative, either physically or verbally. These are all signs that there could be pain. We typically, some patients, some family members, and I had this happen the other day, was a family member called in and told me about the patient who was having these behaviors, these negative behaviors. And as we went along in the conversation and I asked some questions, we found out that the patient was actually constipated and was having pain. And so when there's behaviors there, it's typically, it could be a lot of things, but pain is one of the things that causes them to, when they can't speak or tell us, to act out and have negative behaviors. So we always want to rule out the physical problems or causes first. But if you flip over, there's a little tool that we use, and I know I used this a lot when I was working inpatient. Still use it here occasionally. We do have patients, a lot of our patients are early stages of their dementia who they can still tell us when they're having pain, and they can still rate that pain. So the 0 to 10 would be the early stages of dementia. The pain pain assessment in advanced dementia, goes by the nonverbal, the body language. So if you look at the chart, it looks at breathing, negative vocalization, facial expressions, the body language, consolability, and it's out of a score of, 10 points is the highest. That means they're in a lot of pain. So, we look at that, and there's a lot of different types of pain. There's chronic, there's acute, there's arthritis, there's circulatory, or do they have a UTI? Are they having urinary retention? Multiple reasons they could be having pain. First of all, they're an older person with everything that goes along with that. And then, of course, with the dementia, they can't tell us. So this is a little tool that I use to determine if they cannot express their pain verbally. Rhonda, you got anything else?
The only other thing I would add, and this is for our early patients, we sometimes see, the patients will say, oh my gosh, my pain scale is a 9 or a 10. And again, like Wendy said, look at those behaviors, are they distracted, or are they able to kind of carry on, normal with life, making sure what they report and what they kind of demonstrate at least equal out a bit. And the other thing is, often we still see, routine pain medications on our medication profiles. And so we talk to our families about scheduling those things routinely, even things over the counter, like the Tylenols or the Advils, with the PCP's guidance and direction, making sure there's no contraindication to that, scheduling those things so that you don't have those behaviors that Wendy was speaking of, because often once you have a behavior, then you're chasing the rabbit to try to identify what the cause is and then treat it with the medication.
Thank you, Wendy and Rhonda. And this pain question is so important, because we don't want to undertreat pain, which is a problem, especially in caring for older adults. We don't want to overtreat pain, because the pain medicines and the agents that we often use for younger adult care can be actually counterproductive for the older adult and contribute to delirium and confusion and constipation and things like that. And it's a juggling act. And I think the main thing is we treat patients, not a pain score, as just kind of a walk away message on that. We're going to move next to Dr. Bancoli. And we're going to talk about the managing the psychiatric and the treatment of the behavioral and psychiatric manifestations of this condition. And that was my timer. Dr. Bancoli, what are your experiences and what do you have to share with us as a group?
All right, so I'm going to introduce myself. I'm Kemi Bancoli. I'm a professor of psychiatry and a geriatric psychiatrist here at the Center for Healthy Aging. I always like to start off when I'm talking about something by defining what I'm talking about. So, the behavioral and psychiatric symptoms, also often referred to as neuropsychiatric symptoms, are sort of symptoms that are not sort of the core symptoms of dementia. So when you look at the core symptoms of dementia, we're talking about deficits in at least one domain of cognition and deficits in functionality. The thing about these behavioral and psychiatric symptoms is that they are almost universal in patients and persons with dementia. Most studies state at least a 90% prevalence rate. The Cache County study actually found that over the course of dementia, that 97% of the participants in their study had at least one neuropsychiatric symptom. And when we talk about these symptoms, includes things like agitation and aggression, and both of these can be both verbal and physical. apathy. Apathy is one that may be overlooked, and that's because the person is not, doing that much. They're, just wanting to either stay in bed or stay in a chair, not really wanting to participate like they had been before. And we talk about depression and anxiety, psychosis, disinhibition, and these are the sort of the different symptoms that we see and we sort of think of as neuropsychiatric symptoms. Now, you may ask, how do we screen for these things? So, and everyone this afternoon has talked about talking to the patient, talking to caregivers. So the number one thing is ask questions. Your history is really important. It's very important. So you want to name the symptoms. But aside from naming the symptoms, you also want either the person with dementia or their caregivers, their families, to describe those symptoms. Because you may be talking about two different things. Because sometimes I'll have families report that the patient is psychotic. Or the patient's having hallucinations. And when they describe, I said, what do you mean by that? Describe what's actually happening. They're describing delusions, right? So you want them to name the symptoms, what is actually happening, but also describe those symptoms. You want to find out if there are any preceding events that sort of work up to the particular event or that particular behavior. So maybe that is something that's triggering it, and all we need to do is remove that trigger, right? You want to find out how severe those symptoms are. Is it something that is, it's not causing any issue, it's not causing any distress? So when we talk about management and we talk about medications, a lot of our medications come with serious side effects. So we want to make sure that we're not using them willy-nilly and we're using them judiciously. So you want to find out the severity of the symptoms, the frequency and timing of those symptoms, and then safety assessment. Everyone's been talking about safety today, and that's a really important part of the questions that you want to ask. And when you have the person with dementia in front of you, you want to be observant, and not just of the person with dementia, but of the caregivers. So if you're asking questions and you find that people are, sort of hesitant to answer questions, that may be a sign that the caregivers realize whenever they talk about the symptoms that the person with dementia has, that actually escalates, agitation or some of these neuropsychiatric symptoms. And that may be a cue for you to ask, the caregivers those questions in a separate room, somewhere where the person with dementia will not be become upset by them. Right. So it's important that you are observant with both the person with dementia and the caregivers. And if you can use screening tools for example, the geriatric depression scale. And that scale actually factors in cognitive decline with the questions, because usual depression screening may not pick, or maybe it may give you a false positive of depression, and that symptom is actually directly related to the dementia itself. And we ask, why is it important to screen for these symptoms? And I would say that it's important not just for the person with dementia, but for the caregiver as well. These behavioral and psychiatric symptoms of dementia often predict worse outcomes for both of them, for the dyad, the person with dementia and the caregiver. Persons with dementia tend to have poorer outcomes, including greater risk of long-term care placement. The number one risk factor for transitioning from in-home living to a long-term care facility is actually agitation, and specifically aggressive aggression. And then they also have increased risk of morbidity and mortality. Now, the caregivers, on the other hand, the caregivers of persons with dementia have higher risks of worsening mental and physical health issues, as well as increased risk of new onset physical and mental health issues. And there's studies that have shown that caregivers of persons with dementia have worse physical and mental health outcomes not just compared to folks who are not caregivers, but also folks who are caregivers for other illnesses that are not dementia. Now, when it comes to management, so I know this slide says treatment, But treatment implies that, that we can cure this. So I like to use the word management, all right? When it comes to management, you can do non-pharmacological or pharmacological. I want to spend most of my time talking about non-pharmacological because that's what's better for persons with dementia. And I will say the number one thing that we need to do with regards to management is psychoeducation. So this is very important for families, especially those who are, this is the first time they're dealing with these symptoms. This is the first time they're dealing with psychotic symptoms in the 40, 50, 60 years, however long they've known that person. And it helps to reframe the symptoms for them so they understand that this is part of a disease process, and also that the person is not doing these things deliberately. So I often hear that they're either being difficult, they're doing this deliberately, and psychoeducation can help the caregivers understand that actually, no, they're not doing this deliberately. And what that does is help them change their approach to the person with dementia. And that may be enough to help with managing these symptoms. Anything that we can do to minimize sensory deficits, both auditory and visual, you want to, have them wear their glasses or wear their hearing aids. That can be really helpful. Evaluate for potential medical problems such as infections or pain, like that's been discussed. But you also want to evaluate for possible drug side effects. Sometimes, I have patients and families who are having, the patients having issues with sleep. And they just give their loved one a Tylenol PM or an Advil PM. And the problem with that is that the PM part of that is Benadryl, which is anticholinergic, which can cause these behavioral and psychiatric symptoms. So you want to evaluate for all the medications, both prescribed and over-the-counter medications that they may be taking. And then another part is you want to make sure that you are looking at safety. Whatever your intervention is, it is taking that into consideration. All right, thank you.
Kemi, I'm gonna pause there, and because there's another side of that, the emphasis that we have as doctors and teams caring for these patients is non-pharmacologic interventions, and we'll save pharmacologic interventions for maybe after conversation or for another presentation. We're going to move to the next slide here, where you and Dr. Reynolds are kind of talking about the treatment of dementia. And I'll just kind of lead with this, just kind of watching our time here. Treatment, the treatments out there in terms of traditional medicines don't do much in terms of making things better. How do you advise patients on treating dementia? And Ian, do you want to start with that?
Sure. It's a discussion I have with folks. I'm sort of a little bit more of a pessimist about the medication options for major neurocognitive disorders, the dementias, but they do exist. We have acetylcholinesterase inhibitors. We have memantine. I often start, just like Dr. Bancoli did, I start with non-pharmacologic options, not just for behaviors, but also for things that we can do, especially with early changes in memory, things like exercise, focusing on diet, focusing on socialization, other interventions first. I also like to gauge, a person's willingness to add another medication. They may already have a large pill burden, and so I do like to assess whether or not they want to add other medications to what they're already taking, or if it's already a struggle to add medications, or we're already having issues with adherence, then it may not be the right thing. I'm fairly realistic about maybe what to expect. Again, as Dr. Bancoli said, we're not treating necessarily, but we're trying to hopefully slow the progression of disease with the medications that we have available. And, there's maybe some small evidence that happens. I do, of course, counsel about side effects and the potential for side effects. And in that, it ends up being a shared decision with patients and family about, there are options available. These are the realistic expectations. Here's what we need to watch out for side effects or medication interactions, and recognizing that, it can be frustrating as there are not a lot of other options for treatments for individuals with dementia. So I again, just provide tangible, realistic expectations and engage family in a shared decision-making about what they'd like to do for their loved one.
I agree with Dr. Reynolds. For me, when looking at these medications, specifically the anticholinesterase inhibitor and the NMD antagonist, is that you have to be very realistic with when you're discussing these with patients. So I always tell them that we do not have any disease modifying drugs, right? And that the benefits of these medications are modest at best. I will always, with the caveats that Dr. Reynolds mentioned earlier, I will discuss using these medications with my patients and their family members. And I will leave the decision as to whether they want to use it, how long they want to use it, when they want to stop it. I will leave that to them, right? Knowing that I have given them all the information that I'm aware of and that they're making those decisions based on that. I tell my residents and students that with these medications, you can't be prescriptive in a way. It's not like a patient with schizophrenia or bipolar disorder that has to be on a particular medication. It's not like that. So it is, you're working hand in hand with your patient and their families. So I will, when they say they want to stop the medicine, I will stop the medicine. If I say, let's stop the medicine and they say no, I will continue with the medicine. So it's a two-way conversation with me and my patients and their families.
Great discussion, and thank you both. We're going to move on, last but not least, to our social work team at Center for Healthy Aging, Ms. Amy Shorter-Holland, Ms. Jennifer McPherson. If you can introduce yourselves, and then you've got the next three big topics here, and I'll let you run with that, and you just tell me how you want me to advance the slides. We're talking about caregiver education and support, advanced care planning, and palliative care planning, and then resources.
So I'm Amy. I am one of the social workers here at the center. And just to start, something that really separates our clinic from other clinics is that our emphasis is not only on the patient, but also the caregiver. Just like Dr. Bancoli was saying, we worry a lot about the physical and emotional toll that caregivers face, because this is often a very long and challenging journey, and people will neglect their own care and trying to care for someone else. And a lot of times the immediate family members are in the role of caregivers. So even that dynamics and how the relationships can change as they take on a caregiver role is often very difficult for people. And people will withdraw from social outlets that they once had and take the behavioral and sometimes personality changes personally, further isolating themselves. So what we can do here, and I was trying to think about what the biggest things that we do here to help caregivers, but the number one thing, honestly, is listening. Oftentimes, we are the first contact that they have because of the isolation, even from family members not wanting to express what's going on as far as their loved one and a cognitive decline. So just listening to them and validating them and connecting them is super important, but also the educational piece and providing information on a diagnosis. So Dr. Reynolds talked about oftentimes people don't come with a diagnosis. So talking about that and providing the information specific on that, it gives them information on what they can expect, and in return that gives them control. Like he said, people leave here actually on a more positive note a lot of times, and I think that honestly is the sense of control that they gain from, okay, at least we know what we're dealing with now, and this helps people to plan. So I utilize information from the NIH and the Alzheimer's Association to provide to people. Just in reading that and expressing what's going on at home is really beneficial to caregivers. A lot of times the caregiver will actually ask if counseling is something that the patient should utilize, when actually it's something that could be beneficial for them. So that's something else that we talk about as well, as a way to be more connected and have an outlet. And we'll talk more about the resources in the future slides, but just connecting them to resources is important. And doing that early and being proactive when having these conversations helps us to start at a point where we're talking about the healthy aging brain and how to prevent burnout and connect them to groups and utilize things in the community, versus if we're starting at a crisis point, it's harder to plan those things better. So, and then we'll also talk about advanced directives too in the next slide.
Yeah, and one of the things, so I'm Jennifer McPherson. I am the practice manager here at the Center for Healthy Aging for Geriatrics and Palliative Medicine. I'm also a licensed social worker. And one of the things that I would like to add to what Amy said is, although we consider a lot of the patients that we are seeing here early on, they are often coming to us in crisis mode. So if there's anything that we could do with our PCPs and other medical providers, professionals out in the community, is trying to help family members early on start to identify what's going on, because we are the only service in the area that provides the extensive evaluation and education. So oftentimes patients are being referred to us when they're in crisis mode, and by the time they get to us, they're several months down the road from there because of the backlog that we have. A few statistics just in talking about caregiver burden and the caregivers who are predominantly taking care of our patients. Fewer than 10% of older adults receive all of their care from paid workers. So that means that unpaid caregivers are primarily family members, and it also includes other relatives and friends. Family caregivers deliver 80% of care at home. And honing in on what Dr. Bancoli mentioned about the emotional, physical, and mental stress on the caregivers, in 2010, it was found that family members provided 17 billion hours of unpaid care, valued at more than $202 billion, and that their medical expenses were an estimated $7.9 billion in additional healthcare costs. So moving to advanced care planning and palliative care planning, again, one of the most important things that we want to see, and we start right away when we see the patients and family members in the clinic, is that we need to get that plan of care, the ACP, done right away. Communication about end-of-life issues should be initiated prior to the diagnosis, or at least in the early stages, because with declining cognitive function, it really impacts the patient's ability to effectively communicate what their wishes are. And if these wishes aren't expressed, and if we don't have that documented, it really increases the providers, the caregivers' emotional burden related to therapeutic interventions. And then advanced directives really should be reviewed as soon as possible, and also continuously, to make sure that the decisions still align with what the patient's wishes would be. Some of the topics that should be covered are those related to hospital transfer from home or the nursing home. How do we want to treat infections? Does the patient want to receive artificial hydration or nutrition, mechanical ventilation, or CPR? It's really important that we discuss with the family the reality of what CPR does to our older patient, and that it is actually seldom effective in improving the quality of life, as well as the artificial nutrition is also seldom effective in preventing aspiration pneumonia, improving functional status, or in extending life.
And then just something that I want to add is that it's also important for families to talk about a plan B, because usually a caregiver is a spouse and also has their own health issues going on. So if there were to be an emergency, how to plan for that, what should happen in that situation. And something that we discuss here sometimes, if you're looking to have conversations with patients, is the My 5 Wishes, and also the post form can be effective as well.
And then I think we are talking about resources next.
I'm sorry to interrupt you guys. Great. I know we're at the end of our hour. So if any folks have to jump off, I just want to say thank you for being here. For panelists and Dr. Unwin, if you're willing to stay on, we can continue the conversation. I just didn't want people to feel like we were being good stewards of their time. So
Appreciate it. Thank you.
So sorry to interrupt.
No, absolutely. I think if we can't get any further, the biggest thing that we want our patients and families to know early on is that insurance does not cover the needs that are related to dementia care. A lot of times our patients and family members come in and they think that Medicare is going to cover the needs, rather that's in-home care, 24/7 sitting, and it doesn't. It of course covers skilled related needs, but oftentimes what we're seeing is not considered skilled needs. And so we want family members to start having discussions early on about their finances, what's available in the event they need 24-hour care. What does that look like? We also look at things in terms of finances and assets. We have family members come in where their loved one is pretty far down the progression, and they're looking at moving assets in hopes that they'll be able to qualify for Medicaid. This is something that really has to be started much earlier on, because there's that 5 to 7 year look back period that Medicaid does, which would make the patient completely ineligible for that period of time. And then Amy's going to go over a few of the resources.
Yeah, just to list off some of the resources that we often recommend. There are several adult day centers in the area. There's 2 in Roanoke, the Fine Hour Center and the Roanoke Adult Day Center. There's also one at Virginia Tech and one at Bedford as well. The local Office on Aging is something that we also recommend for Meals on Wheels, Diners Club, questions about Medicare, and sometimes they have funding for counseling services, medical transportation. The PACE program is another option that we will recommend to people. In-home caregivers, which are usually, like Jennifer was saying, private pay. The Alzheimer's Association, Project Lifesaver is another option that we will send people who have concerns of wandering. There are some local facilities that do respite care for caregivers. And sometimes this is a great way if someone is thinking about the transition to an alternative living situation, to have someone come in as a respite stay to see how the transition would go to an assisted living setting. Also, Medicaid has paid caregiver programs that we will encourage people to look into if there's a family member that wants to take that on. There are support groups that are both in person and online. The online groups are rapidly increasing, and there's some groups even on Facebook with thousands of members, which is, I think we're going to see more of that in the years to come with the use of social media and having support groups. There's also information that we'll give out on various GPS tracking and medical alert options for keeping people at home. So that's just sort of broadly describing some of the resources that we will talk with families about.
I want to point out just to close, that often I encounter doctors or audiences when I'm speaking that, basically people say there's nothing we can do to take care of patients with dementia. And I will turn to you and say, when you look at everything we've talked about today, through the course of disease, I think there are 23 bubbles in that graph. There are 23 things that we can do depending on where a person is at in their stage of their disease, that by working with the patient and the caregiver, we can help them in very traditional but non-medical ways, and that these are impactful interventions that we can do as individuals, as doctors, as nurses and therapists, that can really improve the quality of life for the caregiver, improving the quality of life for the patient. And just remember, there's a lot that we can do out there. I think the last slide, a couple last slides here, this is a graphic from the home health program, but it takes a village, to use that term earlier. It begins with the patient caregiver dyad, working with the doctor team, and then beyond that, the therapy team, and beyond that, working with community resources, and then beyond that, working with our policymakers, our politicians, working with researchers to try to do everything we can to improve the quality of care for the patient and caregiver that are suffering from these conditions. Ran a little over, apologies, but thanks for listening. We hope you have a good day, and we'll take some questions for the remaining people that are here.
Yeah, and no apology necessary for running over, but thank you guys so much. You guys are doing amazing work, and some of my colleagues and I were chatting in the chat during the session and just commenting on what a wonderful team approach you guys are taking to the care, these patients, and putting them at the center of your work. So we really appreciate you guys coming and sharing these great resources with us. Deb has posted a CME evaluation form in the chat a few times, so please make sure that you complete that and give our presenters a feedback. Thank you again to all of our panelists and to Dr. Unwin for facilitating this discussion. If there are any questions, I know we have ran over time, but if folks have time to stay around, that would be wonderful. So. And there's been a lot of chat, but I don't know that I don't think I've seen any questions come through, just a couple of comments about great session.
Appreciate it. My thanks to everyone that put some time and energy and heart and effort into this on the team. This is a great group of people to work with, and I have the best job in the world. Thank you, everyone.
Thank you all. Have a wonderful rest of your day.